Well, hello, my name is Al Marati. I'm here in Seattle, Washington, and it's my privilege to be here talking to you about vocal fold paralysis. Thank you for including me in your ACA. I'm guessing it's mostly otolaryngologists with me. There may be a few ophthalmologists that drifted into the room as well. The original title of this talk, I think, is a good one for perspective. Vocal fold paralysis, what have I learned in 20 years of practice? And in many ways, the fundamentals are the same, but I think in a lot of exciting ways, things have improved. We've had a broader idea of in what ways vocal fold paralysis manifests beyond just hoarseness, a better way of working folks up, doing less, and then ways of treating them. And really, it really is mostly about the facility and ease of doing awake injection laryngoplasty and doing it earlier and earlier in treatment. But we'll flesh this out. We'll talk about more. I've noted relevant disclosures. I will be talking about, for example, Restylane, which is a commonly used filler agent for facial rehabilitation, and but is also the one I happen to use mostly in the larynx. It's not FDA approved for this particular indication, as far as I know, but it's something commonly used. I have no relative financial disclosure for that. If I had to summarize, vocal fold paralysis in 20 years, it's definitely not the same disease you learned about in your training. The nature of it has changed. We'll talk about that, how to work it up, and how to manage it. And then we'll talk a little bit about the future, right? What is it going to look like in 20 years when I think a bunch of us will probably be retired by then? Some of this is captured in the evidence-based publications here. One is in clinics, otolaryngology clinics. And then with Dr. Misono, I was a faculty member at University of Minnesota, and one of our former residents here in Seattle. She also provided a chapter in this evidence-based clinical practice book. So I'm happy to send out those references. So what are some key things? Now, this next slide or two is going to be pretty dry, but we're going to get into really the heart and the feeling of a lot of what we're doing in addition to the evidence as we go. Well, evolution and evidence, right? What are the things we thought we know? Why did we think we knew them? Clearly the unilateral vocal fold paralysis, or vocal fold paralysis, as I'll say, continues to have a broad range of possible categories and etiologies, including post-surgical or iatrogenic, neoplasm related, so from a tumor somewhere along the course of the nerve, and the big category, and maybe even a bigger category than it used to be, is idiopathic. I'm not sure why that is, but those are some of the numbers we're seeing. We've learned from some retrospective studies and evidence-based reviews that the workup for the non-mechanical or no obvious cause, they didn't just recently have a carotid operation, those sort of idiopathic paralysis workup should include CT scanning along the course of the nerve, but really skip any other blood tests or lab tests. EMG, interestingly, continues to be better and better year after year, papers after papers refine its use, but it's less and less popular in many ways. It's very good at predicting poor prognosis in most cases, right? If you have an early laryngeal EMG finding in a patient with an unknown outcome, it's not like that tumor surgery that cut the nerve for sure. It's really good at predicting poor prognosis, but in the ones that are not clear, it's not always that great at predicting good prognosis. This also introduces the element of synkinesis, in which the nerves regenerate and they heal, but they don't have the same volitional control over adduction and abduction with the ease and facility that we need to communicate, eat, sing, all those things. Voice therapy is beneficial, but it's not sufficient for most of our patients with unilateral vocal fold paralysis. And a couple other these are bullet points about the fundamentals of what we learned, and we're going to go into the details. In the short run, injection medialization, injecting the vocal fold, wherever you do it, awake, asleep, really does achieve comparable results in terms of the outcome, not the duration, to standard framework surgery or medialization. Interestingly, in comparative prospective studies, thyroplasty and renovation also achieve general outcomes. Whatever we do to medialize the cord, it's probably going to be pretty good. There's some refinements to talk about. Whom we suggest this to or offer to, how we do it, when do we do it, that's really the heart of the discussion, I think. This is an example of how things have changed, I think. This is a patient I saw
just breathe through your nose.
A few years back. A 41-year-old lawyer, 2 months after a thyroid lobectomy with a pretty dense paresis.
Good, you're doing very well.
She's
okay?
making
contact. I want you to do a little teeny baby.
She has a little bit of a
little
bit of phonotrauma there, but she's making contact. She's not moving, but she's limited. She can't get through her afternoon meetings. It's very difficult for her. and we did an awake on injection augmentation. I mean, when I was in residency, we never would have touched this patient. I don't think we would have, mild vocal fatigue with a relatively medialized cord, it's not that lateral. And here she is 2 months after augmentation, still not moving. Her pitch is normalized as her strain has come down. Much better closure. I think this is an example. The early augmentation, because of our facility, the material's better. We're doing awake injections through 27 and 25 gauge needles in the office. I think we're treating more and more patients, and I think that's helpful. I think that has helped people over the years. And I think that's one of the main things we've done for these patients. As our facility with doing the procedures we've become more facile with it, I should say, our targets for intervention are easier to achieve, right? They're easier to see. When I don't have to take the patient to the OR, it just gets easier to convince or offer this to a patient, particularly given the iatrogenic environment they're often in. Many of these patients have had either surgical or maybe related to the tumor, but somehow around their care, they end up with this vocal paralysis. And it's hard to say, hey, have I got an operation for you? But if they do it in the office, that sort of procedure, it may be more acceptable to them as well. So I think this is a really good example of like how we're doing things differently than we did 20 years ago. Reminder for some of the students that may be on, we're really talking about the geometry of the vocal fold here, right? It's a bit of an oversimplification, but when we think of vocal paralysis, it really fundamentally is a geometry problem. The patients have normal vibratory capacity. The cords are sitting there ready to vibrate. They don't scarred, they don't have growths on them, generally speaking, but they're not in position. And even when they get to position, they don't hold position and they don't resist the other moving cord moving against them. So they have a geometry problem, but not a vibratory problem. Many of the disorders, lumps and bumps in the cords, have a vibratory problem. And some disorders have both, but vocal paralysis is predominantly a position and maintenance of resistance to have appropriate glottic valving. The nomenclature is important. Again, a bit of a dry slide, but paralysis is ideally, this is something where the status of the innervation of the cord. So they've have the nerve cut and it, or they've had an EMG that demonstrates the lack of volitional signal. Immobility is a reasonable clinical description. Patient has a symptom, I look at their throat, the cord isn't moving, it's immobile. Motion impairment is a little bit more encompassing term where it's not immobile, but it ain't moving quite right. And somewhat ham-handedly, we use the term paresis when it's moving, but it's not moving normally. And we imagine that this is the electromyographic analog to this. So we should talk about this. Vocal paralysis, vocal motion impairment is not all or none. People aren't either paralyzed or not paralyzed. The recognition of the contribution of partial impairment on symptomatology and its relationship to physiology is another one of the great developments I've said, I believe, over the last 20 years. And I'd like to spend a bit of time talking about that. The punchline is when patients have symptoms, you look down their throat and it looks asymmetric, it probably represents physiological change or aberration. So we should talk about that. Vocal motion impairment paralysis matters. It affects patients' quality of life. It affects physiology. The nature is changing. We'll talk about that a little bit. And as I said earlier, even subtle abnormalities on laryngoscopic exam reflect real pathology the majority of the time. Let's move on. Injection laryngoplasty we're going to talk about appears to be safe and effective and well tolerated. And as I said, as the obstacles for treatment are lowered, the indications for treatment have expanded. And I think we're reaching patients. Lucian Salika, one of my friends, described this where have we come in 20 years? He described, I think I'm getting this right, he described awake injection laryngoplasty as the sand that went under the spinning wheel of laryngology. All the problems we were hoping to solve over the years, dysphonia, strain, we've been more easily accessed with the facility of doing awake injection laryngoplasty. So let's start with the fundamentals. Who gets motion impairment? Who gets paralysis? Who gets it and why? Well, in the old days, it used to be 1/3 neoplastic, 1/3 idiopathic, 1/3 iatrogenic. And that has probably changed, with the increase of spine surgery, with the increase of thyroid surgery, we are seeing about 50% of the cases as iatrogenic. And not necessarily surgical misintervention, but at or related to the time of surgery. Or some other intervention. For about 40% of our patients, I think I have a slide for it, it's just in 1 year study, but this holds over the years, about 40% of the patients are idiopathic. We still don't know what it is. We have some ideas about that it may be related to a herpes virus. And then the other contributions, neoplasm and miscellaneous, are relatively low. In general, the relative incidence of iatrogenic paralysis is on the rise. We talked about precis and paralysis. This is an interesting patient. This patient with an idiopathic change in the voice, no real cause. And even on his clinic exam here, you can see the right vocal fold is reasonably contoured and the left is just thin. I mean, here's the infraglottic edema or a little bit of sulcus or pseudosulcus. And look, this right chord is pretty bulky. Now, I don't know if it's just the way the false chord is sitting, but there's really not a lot of true chord visible bulk on the left. Interestingly, when we play this video,
say we mow our lawn all year.
We mow our lawn all year.
his chords move fine, but he's got a slightly bowed right side and a really empty left side. So I don't know quite what happened to this guy, but this guy's leaking, you know, and when we see these, when we see these abnormalities, you know, we don't quite know what's going on. We know it just is moving, but it's not moving or it doesn't have the right, not moving normally. And here he is. I show this picture. This is a 70-degree telescopic view in the operating room. I took him to the OR for his augmentation. I do most of them awake, but look at this ribbon of a vocal cord, right? It's moving, but look at these two sides, right? And this is really striking. So what is it about this? This is not a sudden loss of vibratory substance, right? Epithelium is normal, cartilage is normal, but the subepithelial tissue, the superficial lamina propria and lamina propria are probably not different in this patient. The thing that's changed abruptly is the muscle mass, the muscle volume. You know, the mechanics are working, the cord's moving, it can move on the joint, but this is a loss of muscle mass. We don't think it's related to myopathy just in this muscle. It's something about the nerve to this muscle. And, you know, really did get me thinking about this. And years ago, interesting, Dr. Himanaka, Dr. Simpson, and myself wrote 3 kind of odd little retrospective papers about the same time, all within about a year of each other, looking at laryngoscopic findings in patients with partial motion impairment. They were not paralyzed. The biggest series came from, at that time, Jamie Kaufman, who wrote about 50 patients. But these 3 papers were kind of interesting. In my paper, we had, in 1 year period, we had 13 patients with partial impairment and who underwent EMG. And why they underwent EMG and the other ones didn't, right? And that's part of our recall and selection bias from that patient. But 12 out of the 13 patients that had laryngeal motion asymmetry had neuropathy on their EMG, and 1 didn't. And the one who didn't had been intubated for 4 days and had palpably had joint dysfunction, so had a real mechanical impairment. This led me to believe, at least in this select group, that when we see asymmetry in the absence of paralysis, there really is a neurologic abnormality. At the same time, Yolanda Himanaka and Blake Simpson each reported separate papers looking at stroboscopic asymmetry instead of just gross motion. And then each of them reported about 85% of their patients who had symptomatic motion impairment had stroboscopic asymmetry. Those patients had EMG abnormalities about 85% of the time. So I guess the takeaway for me is when we have a symptomatic patient and we look down their throat and we see something asymmetric, most of the time it represents an electromyographic abnormality. Now, where is it abnormal? Is it the TA? Is it the contralateral CT? All these things matter. But I think the takeaway for me is that we should have confidence in our examination. Even subtle changes in the innervation of the larynx are related to physiology and impact function. And we know this from Jerry Burke's studies and Steve Belamawich's studies. I think I quote one of them here. There's like the takeaway that asymmetry or abnormal findings related to motion on and basically endoscopic exam likely represents some electromyographically demonstrable change in laryngeal function. The basic science pillar to help say, well, okay, Marati, sure you see it, sure you do an EMG on select patients, but why does it matter? Well, Steve Belamowicz did a very nice study showing that patients with quantifiably lower normal motor units had higher translaryngeal airflows. They were leaking more. So quantifiable EMG changes lead to poor glottic valving. Not surprising, but it really took somebody to show this. And recruitment was also associated with changes in maximum phonation time, electromyographic recruitment, right? How much power and how much increase in power with effort were you getting? And did it matter in terms of their MPT, right? How long can they say the vowel? So when I look at this paper, I think, okay, recruitment, MPT, all are affected by the number of motor units. They're connected to this physiology. And then I put that over here as my pillar. I think, okay, in these patients who have symptoms, who have electromyographic abnormalities, can I tie those together? And I think the answer is yes. I really do. I think when we say asymmetry, I think it means physiological abnormalities. This is not the new reflux. This is not something laryngologists, I think, are selling people for explanations for everything. Feels that way sometimes. I don't know if you've got letters back from your local laryngologist, but Parlysis is very common. My guess is that it was probably always there, but we just didn't really see it. I don't know the answer for sure, but this is why I think what I think. And it is not just a road to nowhere, it's a road around the corner to the next horizon. When you see a patient with idiopathic vocal paralysis when there's no real obvious cause for it, for years when I was a resident, right, whether it was facial paralysis or sensory hearing loss or vocal paralysis, we ordered everything, including, they got syphilis testing and, telling the patient and their typically their spouse, why we're doing syphilis testing all of a sudden was occasionally a tender moment in clinic. But when we look at the data, the only one that's even close to being, supported by the evidence is to just to measure a serum glucose. There's a smattering of reports, one particular paper from years ago from Gary Schechter, the late Gary Schechter, showing that there was a higher incidence in our idiopathic patients that had acute onset or diabetes, interestingly. So we basically don't order serological tests for these folks. For radiography, this is for paralysis. We're going to talk about Parlysis in a second. The early papers really tilted towards like a lot of unseen chest malignancy on chest X-ray. And then later they showed that, CAT scan was better, but it really still isn't clear. I just think, I don't want to say medical legally, but just sort of standard of practice. If you have a patient that doesn't have an obvious history for the vocal fold and motion impairment, for vocal paralysis, or immobility rather, I think getting a CAT scan along with course nerve is a good idea. A nuanced addition to that is, particularly for young patients who don't have a good explanation, I would do their scan, and some of these patients I would offer a secondary scan at about a year. There's some old papers that show that patients who have negative initial scans with idiopathic paralyses who fail to recover, which is a big chunk of patients that fail to recover, but in that sort of young, otherwise healthy group, it might be worth another scan. Did their schwannoma show up later? Did their glomus tumor? Things like that. It's not high yield, not a high yield, but it's something worth talking about. But the punchline is, if you don't have an explanation for the immobility, you need to get a CAT scan. But even then, the evidence is pretty so-so, and there's certainly nothing espousing use of MRI and things like that. While there's no definitive paper, imaging along the course of the RLM with CAT scanning appears to be the ongoing standard of care. What's interesting is people ask me this about Parlysis, right? It's same physiology, right? Nerve not working, isn't there something bad? In two papers, one from Emory, one from Mass Eye, they collectively, I think they had about 200 patients. They just had no identifiable benefit for ordering imaging in patients without immobility. So they had symptoms, they had an asymmetry, but they didn't have immobility. And clinically, in my experience, I haven't seen it. Maybe I've missed something. I just don't know, but I just haven't seen it. So when I see a patient with motion impairment and symptoms, but they don't have immobility, I do not order imaging. Now, if they're coughing up blood and they have 50 pounds of weight loss, that's a different story. But for the typical patient, I don't. What about EMG? EMG, it's kind of bad timing for EMG. I'm guessing there's a renaissance brewing, but it's really good at a few things. It's really good is the brain connected to the larynx? So in patients where there's a controversy about fixation from paralysis, so post-intubation, if they've been in a retinoid dislocation, that is very good, because if you stick a needle in the muscle and you get a signal volitionally, that's a sign that the nerve is not interrupted. But in terms of prognosis, it just hasn't been that great in the past for negative prognostication, or positive prognostication. Sorry, it's good at negative prognostication. The other thing that sat on all this isn't that EMG is good or bad. It's just that for most patients, by the time we all started doing more and more awake injection laryngoplasties, when you could have a needle in your neck, would you get a diagnostic needle or a therapeutic needle? And that's what people choose. I say, ma'am, you have idiopathic paralysis that's been there for 3 months. You're hoarse. Would you like a diagnostic EMG that we can decide to stick another needle in you or leave you alone or do an implant? Or should we just do this one simple 25 gauge needle that has therapeutic benefit and you can wait out your recovery period? Some patients choose one, some patients choose the other, but EMG continues to be an excellent way to study the larynx. But its utility, interestingly, for vocal field paralysis, which is sort of the classic indication in laryngology, has this actually just gone down, despite the fact that the test has probably gotten better and better over the years. Good work was done out of Pittsburgh and a few other places showing that there are ways of quantifying some of the recovery. And I think this will probably refine more and more in the future, especially if they can make it non-invasive. Tough to do, but doable, I believe. So stay tuned for this. When would you do an EMG? Well, interestingly, I find that who you do it on is a little more compelling. I found that, just anecdotally, that patients sort of in the inventory part of their health, people between 45 and 60, maybe 40 and 50, 60, I don't know. They want to know. Younger patients don't want to know. Older patients don't want to know. Typically, there's a medical legal element to it. Did I have an injury or not? But the ideal patient is somebody who is between 3 to 6 months after onset, in my opinion. Early on, I just inject them. If they're symptomatic, they get a short-term injection if the likelihood of recovery is unknown. If they're more than 6 months, I just offer them permanent treatment. I've not had a patient, I'll put an implant in 6 months after the onset of their symptoms that I've had to take out the implant. So 6 months is a pretty good rule for me. Doesn't mean they're done healing, just I haven't had to, take an implant out. So between 3 and 6 months, it's useful. Before 6 months, it's usually symptom guided, and usually temporary therapy. And after 6 months, like I said, most people have permanent treatment. So I'd like to shift gears. So how do we actually treat these? We've talked a fair bit about injection laryngoplasty, and we'll talk about that as well. Therapy is important. It is sufficient in many cases. Patients are like, dear God, don't touch me with anything. I just got to recover from this. It's almost always complementary and occasionally sufficient. The way I look at the different treatment options, I think temporary versus permanent, what do I really want? Endoscopic versus open, awake versus asleep. Some patients, they don't want to be awake during mythoplasty. They don't love the idea at all. And that tips them towards, for example, doing reinnervation. But those are some of the decisions I try to make, or the distinctions I try to make. So this is a traditional thyroplasty, which is the operation is now 105 years old, believe it or not. A reinnervation is over 100 years old as well, too. It just amazes me. This is a classic, it's a bit of an old diagram. Back here in the 90s, Netterville used to, who I learned from, used to split his implants to put them in, but I don't know if he does it anymore, but I don't. And this is a traditional implant done awake in a patient. I use a flexible scope to guide my vocal position and monitor the airway throughout the procedure. And in a smaller fraction of patients than I used to, I'm doing a written reduction. It's a harder operation, it takes time, it's more unpleasant for the patient, but boy, it is really useful when you're not getting a good posterior gap closure, or it's somebody who has reasonable closure, but they have high voice demands, like, some 40-year-old, I'll use that. The patient, the lady I showed with the patient, with the lawyer with a small gap. Now, if that patient was immobile and really had high voice demands, I would consider written reduction on somebody like that. For me, it has as much to do with voice demands. I don't like doing a lot of posterior surgery on older patients. They get a bit of swelling, it's unpleasant, they can have some airway problems. Uncommon, but this is traditional thyroplasty. And for those of you who haven't seen a lot, this is just me playing with the vocal cord on a patient.
Okay, go to work. Address, please.
17820 Smoky Point Boulevard.
Now, don't push. One more time.
17820 Smoky Point Boulevard.
Good. Count to 5.
1, 2, 3, 4, 5.
So voice isn't perfect, obviously,
Again.
but we got to try to
1,
find the
2,
sweet spot
3.
in these patients. And it's a pretty cool operation. I mean, that's the operation make me want to go into otolaryngology. I remember hearing about this and scrubbing in on one early. So I would say this is another lesson we've learned. The vocal field paralysis treatment matters. I'm so happy, I'm satisfied, the patient's happy. Oh my gosh, I got my voice back. So it's unambiguously clear that patients who have treatment get better. I mean, formally, but just, when we study these patients in a programmatic manner, they have dramatic improvements in their voice specific or laryngeal patient reported outcomes and general health things. But what's striking about these patients, study after study, is if you can easily show they're way better than before. But if I take a post-op, happily treated paralysis patient, they're nowhere near normal, at least in their patient-reported outcomes. They're a long way from home. So I say thyroplasty is great, isn't it? But it is, because it's a great treatment. But I would not kid ourselves that these patients are normal. I've done, I don't know, when I wrote the slide of the 800, probably 850 thyroplasties, and one of the more common causes I have, which is not awesome, is not recognizing the contralateral volume loss. So we occasionally do bilateral thyroplasties for unilateral paralysis. They have got some bowing. I see the patient, they have a breathy, bombed out voice, and they have an immobile, concave cord. And I think, oh, that's what I need to do. And then I get seduced by that. I don't recognize just how much thinning they might have on the other side. So just a good reminder myself to do that. What do we do with a radiated patient? This is another example of how things have changed. When I was being trained to do this, I think Netterville's original 93 paper, if I remember correctly, and definitely Harvey Tucker's seminal early paper on complications from thyroplasty, I think 92, I could be off by a year. Basically the message we received was, don't do thyroplasty on radiated patients. And we didn't. I mean, a few people did here and there, but this murmur started to grow. We're just seeing all these radiated patients who are getting cord paralysis, cord fixation. And pretty soon in the back of the rooms, the meetings were like, well, I did one and went okay. I did one. And then two folks, Dave Rostow at Miami and Dale Eckbaum at Mayo Clinic in Rochester, I think those were the two main papers. I'm sorry if I got that wrong. They each collated, I don't know, 15 patients, 10, 15 patients, and just said, hey, I did this. We didn't do anything particularly differently. Careful tissue technique, antibiotics, and we did it. And this has changed what I do, and I think what a lot of us do. It has reopened the door for something that we were reasonably cautioned from early on, so we don't take it for granted. But really, we are now doing more radiated thyroplasties than we ever did, mostly because we didn't do any back then. So I think that's yet another example. What have I learned in 20 years of taking care of hook flow paralysis? Injectional laryngoplasty has been really the big change. As I said, the sands under the spinning wheel of laryngology. I want to just talk a little bit about it. So this part's a little dry. Not everyone does awake injectional laryngoplasty. It doesn't make you a great otolaryngologist or not, if you do or you don't, but it is something that's doable. Some of the barriers to adoption haven't been its difficulty. I mean, otolaryngologists do tough stuff all the time. It is the setup, who's paying for it for years, for a decade and a half. We didn't have a code for it. It was all 99 codes. It was a hassle. Now we have a code for it, but it is challenging sometimes to get all the billing right for the material and things like that. So I recognize that. What we learned, one of the biggest papers was a 500 patient review 10 years ago. I was involved with Dr. Salika, Dr. Simpson, some others, and we looked at them, and pretty split pot between the two groups. And basically people turned out about the same, whether you had it awake or asleep. There was really no technical success difference. Vast majority of people had a technically successful injection. Complication rate wasn't really different. And what we learned, even 10 years ago, the trend went upward. Just between 2003 and 2008, 11% of the collected injections were done awake, up to 43, and it's just gone up more and more, particularly within laryngological practices. This is an interesting paper. This is a prospective paper. It's not a huge paper, but it was the first prospective paper on injection laryngoplasty. And what's striking to me, it gets back to that signal. Yes, people are better. Yes, they're happy they did it, but they're still not great. This is the old VHI 30, not the VHI 10, the patient reported outcome measure. So the numbers are a little off from what you expect. So pre and post treatment clearly get better, right? The p-values for improvement in the VHI domains is great. But look at this post-injection voice handicap index. Way better than before, way worse than normal, right? These are not restored people, they're improved people. And that's not to say boo-hoo, this is what we should be doing, but we shouldn't be satisfied that we're doing everything we can for the patient. I think there's more out there. Who gets what, when they get it, what are the indications, what are the techniques? That's all stuff yet to work out. Let me move on here. A couple simple papers that really opened our eyes to this. This very straightforward paper from Kim Vincent, Dr. Vincent at Vanderbilt, showed 10 years ago that they looked at just a handful of patients that both injection and framework, when you take the duration out, because clearly injectables don't last forever, that there was no significant difference at its peak between the outcomes in awake versus, excuse me, with injection versus implant patients. And that matters because the fantasy is if I truly have a permanent injectable, which does not exist, or not without some problems like Teflon, for example, then ostensibly we could have something that would be beneficial for patients in the long run, that the outcomes could be good. It doesn't require framework surgery to achieve this. You can achieve it through an injectable if we had the right injectable. And there's some new injectable materials coming out. Silk, I have not used it personally, but I think it's going to get better and better. One thing I would ask of everybody is, what good is a 2-year injection? Let's say it's exactly 2 years. For a patient who has an early onset, either idiopathic or just had a thyroid, but the nerve's probably okay, why do I want a 2-year injectable? I love a permanent injectable that was easily correctable in case I was not very good at putting in or didn't put it in quite right. But having a 2-year injectable, that's great. It lasts for a long time, but aren't they getting a thyroplasty anyway? Are they going to really have 2-year injectables forever? At least for me, someone who does a lot of thyroplasty, I need a 3 to 4, 5 month injectable. That's what I need. And I get that with Restylane in my hands. There's other ones that are like that too. I need something that supports the patient during their potential recovery period. And then I do a thyroplasty or reinnervation. If I had a truly permanent injectable, that'd be great. That'd be great. One injection, no thyroplasty, no nothing. That's awesome. So I hope that exists in the future, a reliable one that can be patient friendly and all that. So my ears are open. I want to talk a little bit about laryngoplasty for pain. I'm sorry, I skipped over a couple slides. Laryngoplasty for pain is an example of one of the paradigm shifts we've had. This is an example. It's not everything. This is a small paper I did, again, actually with Dr. Shalika and then Dr. Kupfer from Michigan. 8 patients, not a big magnum opus. There's no Nobel Prize coming for this paper. But I thought it was a bit revolutionary because these patients got permanent thyroplasty without having dysphonia as their chief complaint. Their chief complaint was discomfort. In fact, they had relatively mild perceptive and patient-related voice outcome abnormalities. They mostly had pain. And the conjecture, these were almost all young patients, the conjecture was they were demonstrating vocal strain. They were able to make better voice just by straining all the time, and then we were mechanically relieving of them. So this was changing people's voice boxes without them being hoarse in the first place, or particularly hoarse. And it worked. We did injections on most of these patients, then converted in thyroplasty, and by the time we were done, if we saw a patient with a notable gap, with a motion asymmetry, but had very minimal perceptual voice abnormality, they mostly had strain and pain, we went straight to thyroplasty. So what else is there out there that's like this? What subtle swallowing abnormality? I don't know. One thing we're doing more of, it's really out there sometimes, is patients with a subjective sense of dyspnea. Patients with dyspnea with a negative chest workup. We know that patients who have a blown out paralyzed cord, they have a sense of breathlessness when talking, but they also have exertional dyspnea. And I don't know what aspect of it, I don't quite know why it works. I think it may be known, but medializing a cord, statically narrowing their airway, improves their sense of dyspnea. Now, most of those patients have dysphonia as well. So it's not exactly as paradigm shifting as this little paper. But the idea that you can treat breathlessness, the sense of dyspnea, with vocal fold medialization is really kind of out there. We're doing, I'd say, 1 or 2 of these a year. And it has been, I don't want to say uniformly beneficial, but I think it has been. I think those patients have done very well. You just have to choose your patients correctly. Those would be great cases for a temporary injection, right? You don't have a lot of voice complaints. You do have some motion impairment. You have a sense of breathlessness. The chest is okay. We medialize the vocal fold. Does your breathlessness improve? And my colleagues in Turkey did a really cool paper on unilateral paralysis with, I think it was a military recruit group or military group that they did ergonomics and all sorts of physical exercise stuff with them, and their sense of breathlessness and their physical performance, I think on like cycle and things like that, did improve with medialization. It's really interesting. So I want to talk about reinnervation as we close out. Reinnervation has been around for 100 years. Who is the ideal patient? I think somebody who has non-neck-based iatrogenic paralysis. So if they have a skull base or intracranial vagal paralysis, or if they have a thoracic one, those are the best. Patients with neck surgery, no problem. Thyroid surgery is a little tough. If they don't have somewhere to land, if they don't have a stump near the crux or no joint, the operation is still doable, but we have to go into the larynx typically. We have to open the side of the larynx with a saw, crack it open, take off the outer paramecium, I guess it's called, the outer part of the muscle, and just take the ansa cervicalis nerve and sew directly into the muscle, endocyte muscle. It works fine. It does burn a bridge for eventual thyroplasty to do this endocyte. Going back to the main discussion, in general, the reinnervations we do are ansa to recurrent. So ideally, we have a segment of recurrent in the neck, in the tracheoesophageal groove, which is visible in nearly all spine operation iatrogenic paralyses. Tougher in thyroid cancer for sure. Thyroid cancer is tough. But then all the other vagal neuropathies come from surgery, carotid and head neck cancer, schwannomas, things like that. Usually those are pretty doable. Head neck cancer, you have to watch out because the ansa has been blown through. But most of those patients work fine. So I would find a post-traumatic or iatrogenic paralysis patient who has not had neck surgery. That'd be the best person to start this on. What do you do? Well, first of all, it's way easier than thyroplasty. You find the recurrent, which we're all trained to do. You find the ansa. You freshen up the ends and you sew them together. Sew them together under a microscope. I use 8-0 nylon, 3 or 4 stitches. I think other people use finer stitch than that, but it works great. It is particularly attractive for those of you who take care of kids. It is particularly attractive in pediatric vocal field paralysis. Pediatric vocal field paralysis has had some evolution in the last 20 years. The recognition of it, the utility of ultrasonography as a diagnostic, so you don't have to scope kids, is really a pretty good thing. I think we all learned after trying 15, 20 years ago that thyroplasty in kids sucks. That's not a medical term, but it's just been my experience. And injectables are fine, but again, we don't have a permanent injectable. And I'm not sure, do I want a 50-year injectable injected in a 2-year-old? I'm not sure I want that. So we ended up doing what? Wait till right before school, put a little medium turn injectable in there and wait it out till they get big enough to have a thyroplasty. So this is where reinnervation comes in. I do, 3 or 4 paralyses cases, 2 or 3 a year reinnervations on kids over at the Children's Hospital here in Seattle in partnership with our pediatric colleagues. But I think this is probably an operation that is underperformed in our country. There are kids out there with paralysis who should have a reinnervation who probably aren't getting it, to be frank. It's not a difficult operation. So, experience helps, precision helps, but it's not a conceptually difficult operation. Randy Paniello showed us years ago that even in the study that was limited for time, they showed in the true unicorn of scientific studies, the prospective randomized surgical trial, right? It's as good as it gets. I showed it in a group of 24 patients that reinnervation and framework surgery did about the same. And in fact, in younger patients, the cutoff statistically was at about 50, 52, that the younger patients had a relatively better benefit from reinnervation. So we tend to recommend that a little earlier or in earlier patients. But in general, the punchline is, when studied in this manner, prospectively randomized, did I say placebo-controlled? Sorry, I didn't mean that. Prospective randomized surgical trial, that either reinnervation or framework have similar outcomes for patients. That's really, really remarkable. So what's my message over the last 20 years about reinnervation? It should be done more. It's not difficult to do. It is reliable. It's best in patients who have not had a bunch of neck surgery, but it's still possible in those cases. It takes about a year for it to recover. It's not a very good picture. I'm sorry. There's a reinnervation. That's not my best size match here, but it really is an elegant operation. It takes about 3 hours, 2.5 hours. And I typically do an augmentation at the same time because they're going to be immobile, right? So it might buy them a little support over the first few months while they're recovering. It takes about a year to get the final results. On young patients, we start to see, in my experience, tone and a little bit of flicker within 3 to 4 months sometimes, but really substantial recovery in the 6 to 9 month period. Your results may vary. Reinnervation does not burn any bridges for implantation, for thyroplasty, unless you're doing endoside into the larynx, which is needed in thyroid cancer cases. Not hard to do, but you do burn up a bit of a bridge with thyroplasty. Not the end of the world. If the patient wants reinnervation, you give them reinnervation. But it is something to keep in mind. The traditional 98% of these are ANSA to recurrent. Find the recurrent, find the ANSA, sew them together, 8 nylon. It's an elegant operation. So what have I learned in 20 years of doing this? Well, vocal paralysis matters. You know, when the vocal fold motion isn't good, it affects patients. Breathing, talking, swallowing, the impact on quality of life and overall sense of well-being is real. Electromyography, while continuing to improve, has fallen off in popularity, really in the management, having to do with the advent or the really arrival, I guess that's advent, of the facility and ease and of awake injection arthroplasty. I bet it'll be more of a comeback in the future. In the short run, injection and framework surgery work fine. They work the same. We just don't have a permanent or long-term injectable. It's well tolerated, but even then, treated patients are not, they're not normal. They're just a lot better. Keep that in mind. There's no real wrong time to refer the patient for treatment. I personally find it really disappointing, like I'm wagging my finger at people, but I don't like it when patients wait for a year after thyroidectomy, for example. Oh, it might get better, might get better. Fine, it might get better, but why not wait in style? Why not wait in treatment? Now, there's reasons why people don't pursue injection, but you know, reach out to your colleagues who may do this and just say, hey, what do you think about this patient? Chord's a little rough, or vocal fold's a little raspy, voice a little raspy. What do you think? So there's really no wrong time to see a patient for hoarseness if it's a perioperative one. So what do I wish I knew in the future? Who's likely more to benefit in the future, right? Why can't I plug into some algorithm? Demographics, electromyographic findings, laryngoscopic findings, etiology, complaints like voice dominant, airway dominant, swallowing dominant. And there's an algorithm. Oh, if it's a 32-year-old female after thyroid lobectomy, they mostly have vocal fatigue, they should definitely go straight to implant. If it's been more than 2 months or the EMG shows this, right? This is not an uncommon disease. You know, we should be able to figure this out. And this is my hope. I can be supportive, I hope, but really that this next career era of laryngologists helps to ask and answer these questions. When is the ideal time for intervention? That's like that first question, right? Okay, fine. What do I do? But when do I do it? Today, tomorrow? Do I go back? Do I wish I did it already? You know, when do I wait? Are there predictors of outcome? Are there predictors that help drive our decision-making? And finally, what is the nature of idiopathic paralysis? Is it viral, right? There's a couple clues about that. It's a tough one to answer, right? I mean, you know, we've learned from Bell's palsy that it's virally related because when your face stops working, you go see the doctor. You know, when you're hoarse, you probably don't go see the doctor for a day or a week or a month. You know, I mean, half the idiopathic patients you've seen, they've already been given a round of amoxicillin. They've already been given a sinus CAT scan. You know, no one's actually, you know, looked at the throat that quickly to see what it is, or had the sense to, or the cochlear familiarity with what it sounds like to sense that that's what it is. So I don't know that we'll ever figure that out. So the role of early injection, does early injection reduce the need for later implantation? Some papers for it, some papers against it, unclear. Nimlodipine was exciting to help, you know, return function. It's just hard to study because we're not getting early patients very often. And finally, can we control synkinesis, right? Are there aspects of how the larynx renovates that we can act on early, Botox here, Botox there, to help modify their likely recovery? All these are kind of 30,000 feet questions. So I guess I had to summarize. I'd say this is really not the same disease you learned about in your training. The nature of the disease has changed. Our perception of total and partial vocal motion impairment has really matured. Partial impairment matters. Trust your exam. Inject patients early. You do it, knock them out, do it awake, whatever. It all works fine. And just keep your eyes open for the future. I encourage folks to consider reinnervation, particularly if you're taking care of kids. It really is a nice adjunct. So it's my privilege to be here. Thank you for letting me be a part of your meeting. Thank you so much.